We are going to present the case firstly. Clara Hugueto, our resident, is going to present some slides. Clara?
Yeah. Hello everyone. Thank you, Alfonso. I am going to present the first case. We have a 58-year-old male, former smoker. He has a medical history of atrial fibrillation and is on treatment with antivitamin K. He was hospitalized in February of this year because of acute heart failure. A transthoracic echocardiogram was done in which he was diagnosed of severe mitral stenosis with mild regurgitation and a normal ejection fraction. The mean gradient of the mitral valvuloplasty is 12 millimeters of mercury, and the area estimated by 3D planimetry is 0.8 square centimeters. The electrocardiogram shows atrial fibrillation, and the blood test is normal. Here we can see the images of a previous transesophageal study. In the first one, we can see that the valve is not calcified and the leaflets are thin and appropriate to do the procedure. The Wilkins score is 8, and in the second one, we can see the severity of the stenosis with Doppler color, and in the third one, we can see the small area of the valve in 3D planimetry. So we are going to do a percutaneous balloon valvuloplasty guided by transesophageal echocardiogram. Sí.
Okay, so that's the case. As Clara said, we have a severe mitral stenosis, and now Silvia is going to explain us the current situation of the echo.
Yeah, hi, welcome everyone. I'm Silvia Balbuena, I'm the echocardiograpist. So here, I think you can see my echo, yeah? Mm-hmm. Okay, so first thing you have to do is, of course, before we come to the cath lab, we have to appropriately select the case. So that's the, I would say, the main role of the echo, if it's possible, of the transesophageal echo. So first thing you need to check is that it's a rheumatic disease with commissural fusion. I mean, the objective of the valvuloplasty is to open the commissures. So if you don't have a commissural fusion, you're not going to open the commissures and you're going to break the valve. Okay, so you can see here an en-face view of the mitral valve from the left atrium. This is known as the surgical view, and you can see this fish mouth opening of the mitral valve. And you can see that both commissures are fused. So the morphology of the valve is fine. The mobility is a bit restricted. It doesn't have a lot of calcium. You can see here, this ball here, is a bit of calcium in the anterior leaflet, which, well, the best would be no calcium, but okay, it's acceptable. It's not a lot of calcium. And yeah. You can see also here in the 2D view that the subvalvular involvement is not, I would give it a 1 in the Wilkins score. I mean, it doesn't have a lot of subvalvular involvement, which is great because percutaneous valvuloplasty and subvalvular involvement don't go very well together. Okay. Mm-hmm. So we would be ready to start whenever you are, okay. Alfonso and Guillermo.
Okay, thank you, Silvia. We have another comment of the echo. You see some funny smoke in the left atrium. We have now administered a slight dose of heparin before the transeptal puncture. Just we do it in every case. And now I'm going to actualize the setup. We have an 6 French radial sheath just to have a pigtail in the aorta, and we did echo-guided puncture of the femoral vein, just to use one proglide. We use it when we go with sheaths over 14 for the final closure. So okay. we're going to start the transeptal puncture. As you can see, we have the echo guidance. We have the needle pointing in a imaginary clock to 4 or 5 hours, and I'm going to retrieve all the system until Silvia confirm me I am in the exact point of the puncture. We're going to try to puncture posteriorly and
yeah, the key to a safe transseptal puncture is it's very easy with the biplane mode. Sorry. And well, my mean gradient is 8, although it's atrial fibrillation. Okay. We should do an average of several.
There are some questions on the chat.
Some questions of the audience?
On the chat, yeah. The first one is if there is there any commissural calcium, any other negative predictors?
It's for you the question, Silvia.
Yeah.
If there is, in this case, commissural calcium, yes, there's one calcium nodule in the, one second, I will show again, close to the medial commissural commissure, sorry.
¿Está ahí? ¿Allí?
Yeah. So, of course, calcium, the best calcium is no calcium. I mean, but the medial commissure, you can see it here. That is thickened.
Sí, ponlos los dos a 0. Can we do the 0,
here,
please?
This
0?
is the calcium. So the lateral commissure is free. So
while Pilar is retrieving there, we can explain all the things that the Innova balloon has.
Okay. Yeah, go ahead. Go ahead.
Probably, okay. So we have this pigtail wire that we're going to advance firstly through the Mullins sheath to the left atrium. And over this wire, we are going to advance this dilator. It's a 14 French dilator to dilate not only the septum, but also the axis, the femoral axis. We are going to use a 28 balloon. We have 3 sizes, 24, 26, and 28. The measure is more or less calculated with the height of the patient. He's, if I remember well, 178 or 76 centimeters.
Yes, because the valve has a little calcium, but I think it's less aggressive, probably 2 or 3 millimeters less than the.
Yeah, but we have to, with this 170 something, we have to divide by 10 and then assume 10 more. So 170. 17 divided by 10,
26.
Then plus 10 is 27 more or less. So we are using a 28 millimeters balloon, then to be, as Guillermo said, to be conservative. So we, as you can see in the angio, we have advanced the pigtail wire towards the ceiling of the left atrium. We're going to retrieve the transeptal sheath, and we are going to advance through this wire. There is a 0.25 inches wire, the dilator, the 14 French dilator.
Yeah.
It's an important part of the procedure because the Inoue balloon goes without any sheath. So it's important to cross the skin.
Yes. It's very important to open with the mosquito.
So now we are retrieving the dilator, and we are going to introduce the balloon that Guillermo and Pilar prepared before.
It's very important to place the wire up of the left atrium. Yes. That's in this case is perfect.
Okay. We are inflating the distal portion. I'm going to retrieve a little bit, and when we are in the valve. Silvia, please tell me.
A little more back, no?
Yeah, I would say you're in the right position.
Okay.
Sometimes it's possible to make a look in the left. Okay.
You're in now.
Fantastic. Okay.
Inflate a little bit. Okay, I'm going to retrieve.
Yes, back to the.
It's free. Just for the previous question. I'm retrieving it. I'm retrieving it a little bit more.
Okay.
We are in the valve?
Near to the valve, yeah.
Okay.
Yeah.
Let's inflate it. Okay. And down. And I'm going to retrieve the balloon to the atrium. Okay. MR is not.
Okay, 1 second.
Okay.
Yeah, good. MR is still mild.
Should be enough, eh?
Yeah.
While Silvia is measuring the result, just a comment.
Podemos medir el gradiente nosotros.
Yeah,
no son
MR, it has
increíbles.
several jets, but
Perfect.
it's
Okay, ¿no?
very
Now,
protosystolic.
I was saying that this procedure is very uncommon in our country because this rheumatic mitral stenosis is quite rare. But you have to be trained doing this because the patients are there. And for example, today we have done another similar procedure before this live case.
Sorry to interrupt. You can see here in the 3D view that the lateral commissure is open now, and the mobility mainly of the anterior leaflet has greatly improved. Okay, you can see it there. Can you? So I'm going to measure the area again.
The image is quite better.
No, the 3D image looks much better.
Which is the basal area? Which is?
More or less.
0.8.
We are going to enter into the ventricle just because we have an old school friend here that believes in ingredients.
Estoy aquí.
But if we are not able, after Silvia measure everything.
My mentor checked the result with the cardiac auscultation.
The real cardiologist, not us, with all these gadgets.
So just orientate the planes as we did before towards the smallest area.
Okay.
And
¿Cuál
here,
era cuál?
I'm not right.
¿Cuál era cuál?
Que nos enganchen el.
Ok, este es ese.
Vale. Pero tenemos esto.
Quítalo. Saca el estilete. A ver. Vale. Y ahora con la otra. Esta es.
It's big. I mean.
Okay. If anyone can measure the gradient outside, ¿podéis medir el gradiente?
Todavía no ha caído a la diastólica exactamente, pero bueno.
2.3.
2.3.
Yeah.
I think
Very
gradients
very good result.
don't matter.
I mean, you can see in the image that the valve has
clear.
increased massively, especially on the mobility of the anterior leaflet.
I prefer the new way.
And also these funny calcium nodules as well.
Well, the funny calcium nodules, I hope they're still there. Yeah, look, the posterior leaflet
is there.
Calcium is there.
But the commissure is open better.
Again, the ridges
yeah,
is...
indeed, the medial commissure is open as well. That I would aim for the lateral one because the medial one is calcified, but the medial commissure is open as well. So
no sé, bueno, es igual.
The result is very good, I would say.
Have you stored the image of the gradients? Okay.
Bueno, es que pueden hacerlo instantáneamente.
Another important step of the procedure is how to retrieve the balloon, and Guillermo is going to do it because you need to follow step by step the instructions.
First, the pigtail wire with the stretch tube. First wire.
So we insert the stretching tube a little bit only, just to insert the wire, the 0.25 wire inside the balloon. I think we need to deflate the balloon better.
Mete el plateado. Mete el plateado, si no, no te irá hacia arriba. Mete el plateado. Ok. We need to advance the stretch tube.
It's inflated, the balloon. You are seeing
okay,
it
yes.
Okay.
So, Guillermo, yours.
Sujetarlo un poquito ahí. Bueno, vamos a esto.
So we need to deflate the balloon better, and then the steps are similar than before.
Okay.
The wire is there, up in the left atrium. We're going to advance the silver one towards the golden one, metal with metal.
And now, gold against the key lock.
Metal with plastic, okay?
We retrieve a liter because with the perforation with the left. With this. Okay. No, okay. Yes. Lock is perfect stretching.
Yeah, it's good.
And now we retrieve the wire.
A little bit the balloon as well, because you're in the
No,
center.
but
Okay.
it's okay. It's okay.
Okay, as we told you before, we have prepared a preclosure with Proglide.
And with the balloon, it's smooth, very smooth. No problem. Yes. I know.
So I think we are almost done. We are going to retrieve the balloon and advance the Proglide. Please a syringe with saline.
There's a small atrial septal effect left, of course, which is usually small with a left to right shunt, which is the normal and usually closes after a few weeks, I guess.
No, without. It's better without light for the.
Bueno,
Okay.
muy bien. Voy a volver a...
It's very easy to take.
Sí, bueno.
Yes, no problem. Okay, stretching. Like previous.
So some people use this Proglide to closure even the veins when there are big bore accesses, and some people do some compression or another tricks. We have very good experience with this approach with mitral clip and big sheaths. Okay.
Any questions, Clara?
No. There aren't any new
As
questions.
you can see, it's closer. I'm going to press a little bit, 30 seconds. But I think if there is no question.
No, if you have questions, my Twitter is.
Any other comments, Silvia, Jesus, just before?
No, the result is very good, to be honest, and well, it's a bit annoying because if you look at the calcium, the case was so. There were some concerns about the medial calcium, but the result is excellent. However, so there's some degree of unexpected results that you cannot predict with the image.
Yes, this kind of cases are quite unpredictable, but I think this case is very educative. It's not a so common procedure, and I think we have spoken about a lot of things regarding this mitral valvuloplasty. So thank you all the team. And